Hello, professionals. This is Dr. Saad, and as you know, we are recording a series of lectures for pharmacists who are going to appear for international equivalency exams. And as I briefed you in my previous video, that we will discuss the implication of autonomic nervous system drugs in upcoming lecture, and we have finished abstract study. So you can listen our previous video. I can mention all important points which can be a part of MCQ's question paper in the upcoming exam. So let's talk about the implication of this drug, and the system which I will discuss is excretory system and ophthalmic and respiratory system, and we'll see how we modulate our muscarinic and adrenergic receptor for our advantage. Let's discuss about the first, that is the excretory system. In this system, we specifically use the urinary retention, urinary urgency, and benign prostate hyperplasia. As long as urinary retention is concerned, we specifically, as you know, that when there is a case of urinary retention, we will use cholinergic agonist, and its example is bethanacol. And when there is a case of urinary urgency or incontinence, we will specifically use anticholinergic drugs. That is one of its example is the oxybutynine. And these are the situation because cholinergic action and anticholinergic action are opposite to each other. So we will see patient condition, which condition we will then we will decide either agonist action is required or antagonist action is required. So this was a generally, but basically specifically with the ailment which I am going to tell you here about is the BPH, that is known as benign prostate hyperplasia. As you know, there is a prostate gland at the start of urethra. It sometimes it enlarges. This play a key role in urine outflow obstruction, and this is defined as the BPH, benign prostate hyperplasia. Yes, this is known as BPH. So this situation is very important for patient, and specifically in elder age. So urine outflow obstruction need to be solved so that patient feel normal. So for that, we specifically use alpha receptors, beta receptors, and muscarinic receptors. We will use alpha blocking drugs, that is the alfluzocine, tamsulosin, doxazocine, and prazosine. These are the drugs used once daily, and it is a regular part of prescription. Similarly, we will use antimuscarinic drugs. Its example is the solifenacine, 5 mg OD, and tolteridine, 2 mg BD, and it is used for this situation. Similarly, beta 3 receptor antagonists are an important part of this management. Like there's a drug known as mirabegron. Its dose is 50 mg once daily. It is also used for BPH, and if patient is facing any issue in liver, then its dose is reduced from 50 mg to 25 mg once daily. So these are the autonomic nervous system associated drugs for the management of BPH. And other than ANS drugs, that is the 5 alpha reductase inhibitor and PDAs. As you know, 5 alpha reductase inhibitor is a very common example of it is the finasteride and dutasteride, and PDAs inhibitor is sildenafil, tadalafil. These are also part of the prescription of such type of patient. And sometimes alpha blocker and 5 alpha reductase inhibitor, that is the finasteride or dutasteride, are combined or used in combination. And we also have some pharmaceutical preparation which are available in combination, that is the dutasteride and tamsulosin are often in a single combination. So through the by using these receptors, we manage our urinary retention, urinary outflow, urinary incontinency, and benign prostate hyperplasia and excretory system. So let's talk about next. The next system, that is the ophthalmic control. As you know that our eye contain beta receptors, our eye contain alpha and muscarinic receptors, and we use this receptor for a management of a specific condition that is known as the glaucoma. As I told you that glaucoma is a condition where aqueous humor can't go out, either absolutely it is blocked or it is partially blocked. This is defined, once if it is partially blocked, it is defined as the open angle glaucoma, and if it is absolutely blocked, then it is defined as the closed angle glaucoma, which is a very serious condition. This situation leads to rise of intraocular pressure, which ultimately damage to optic nerve, and it can leads patient towards the blindness. So to manage this situation, our prime target is to reduce intraocular pressure from almost 25 to 30% from the initial pressure. So we use here we again use ANS drugs and use this muscarinic M3 receptor, alpha receptor, and beta receptor for its management. As long as the beta receptor is concerned, we specifically use timolol, and this is used as once daily dosing, and it is very important for the management of glaucoma and for the management of intraocular pressure. Similarly, we use alpha agonist, that is, this example is epropronidine and brimonidine. Brimonidine is recommended to be 2 times per day, and epropronidine 1% drop is also commonly used. It is specifically used for the management of intraocular pressure, specifically after operation, while post-operative intraocular pressure is being managed by the use of alpha agonist drugs. And as I told you, for example, is epropronidine and bromonidine. Similarly, we use miotics, as you know that we use M3 receptor agonist for production of miotic action at the pupil, which helps and facilitates in the flow of this aqueous humerus. So it will play a key role in the management of intraocular pressure. So these are the drugs which we specifically use from ENS to in the management of intraocular pressure. Similarly, some other drugs which plays their role. But one thing I would like to let you know that, for example, when a patient wants for retinal examination, there is a drug known as mydriotic agents. It's an anticholinergic drugs. It's commonly known as atropine. It is being used for the retinal examination because it causes mydriosis. And as I told you about glaucoma, let's discuss also, for sake of information, let's discuss other drugs also side by side. The use of beta blockers and alpha agonist and muscarinic agonist for as a part of therapeutic planning. So complete strategy for the management of glaucoma is use of ocular prostanoids, beta blockers, carbonic anhydrase inhibitors, sympathomimetics, and miotics. As long as the prostaglandins are concerned, you know its examples are letanoprost, travoprost, telfoprost, and bimatoprost. These are all recommended in once daily application. Similarly, as long as the carbonic anhydrase inhibitor is concerned, it's used as acetazolamide, drozolamide, and benzolamide. As well, drozolamide is recommended TDS per day, and benzolamide is recommended 2 times per day. So this is a complete strategy for the management of glaucoma. And look, ANS drugs also has a major share here, and we are using our adrenergic and cholinergic receptors to manage our to manage the situation, and we are using it for our advantage. Similarly, I think you have already gotten my point. So let's talk about the third system, that is the that is the respiratory system. As you know, there is a beta blocker. Here you will see how we use the beta blocker and muscarinic M3 blocker receptors, beta receptors, and muscarinic receptors at our bronchioles to manage the airway obstruction. So as you know, let's talk about the asthma, and in this system we'll talk about the asthma and chronic obstructive pulmonary disease. Asthma, let's talk about it just for a brief review. It's pathophysiology. It's a situation in which bronchiole constrict and inflammatory pathway uh, leads toward the airway obstruction, that is known as narrowing airway caliber. This is the main symptom which is visible for asthmatic patient. It feels difficulty in breathing because of this airway caliber narrowing. So this is the pathophysiology, and there are and we use beta long-acting beta agonist and short-acting beta agonist. Like one of the example, long-acting beta agonist example is the salmeterol and formoterol are the example of long-acting beta agonist, and salbutamol and terbutaline are the example of short-acting beta agonist. It is the major part of for the management of our asthma. Similarly, we use long-acting muscarinic agonist. Its example is the tiotropium. It's also used for the management of asthma to resolve the airway obstruction. Ipratropium is also its part, but it is short acting. Although it is it is used as an inhaler, in a nebulizer, but it is short acting. So let's discuss the complete therapeutic plan. There you will easily understand the position of adrenergic and anti-muscarinic drugs for as a part of therapeutic planning for the management of asthma. So, as you know that once patient is being diagnosed, is once asthma is suspected, then it is recommended to use low dose of ICS, inhaled corticosteroid. And once patient's asthma is confirmed, then there is a four-step approach. At first step, again the same, we will keep it on inhaled corticosteroid and observe the patient. Once its symptom is under control, then uh, this will kept on. Otherwise, we will move toward the next step, that is the inhaled corticosteroid with the addition of long-acting beta agonist. As I told you, that is the formoterol and salmeterol. But here, remember one thing, that never ever recommend long-acting beta agonist alone. It is always recommended with the inhaled corticosteroid. So in next step two, we'll use long-acting beta agonist as well as inhaled corticosteroid. Similarly, at step three, it is a multi-step approach. At step three, we will stop long-acting beta agonist and we will increase the dose of inhaled corticosteroid. And once patient isn't managed by this modification, then we'll move toward the at the next level, that is the further we will add again long acting beta agonist with the increased dose of inhaled corticosteroid, and will observe the patient. If the situation is still out of control, then we will move for our second last step at the stage 3, that is the again the use of long acting beta agonist as well as inhaled corticosteroid side by side, leukotriene receptor antagonist, and long acting muscarinic agonist. This is the point where we start long acting muscarinic agonist, that is the tiotropium, with the theophylline. It's approach at which patient will definitely manage, and once patient is being observed and its airway passage is being kept under supervision under the investigation, and once patient will definitely respond to this approach, and this situation is being managed until asthmatic symptom resolves. So this was the all our therapeutic planning for the management of asthma, and actually why I discussed it here, just to tell you that at which stage our beta agonist and muscarinic agonist, or you can say beta 2 receptor and muscarinic receptor, is being used for its management, and how we are planning to implicate our autonomic nervous system drugs for the management of asthma. This is all my point, which I tried my best to explain you here. Let's talk about our second condition, that is the chronic obstructive pulmonary disease in the respiratory system. And this is our final topic. And after that, we will close this video, and next thing will be recorded in next video. As you know, the chronic obstructive pulmonary disease, its name indicates that it's also airway obstruction. Here we again need the anything which can play a key role in the airway opening and avoiding the narrowing of airway so that patient can breathe easily. So for that, we will specifically use number one, if patient is smoker, then smoking cessation strategy is being used. And as you know, in nicotinic, as you know, that smoking and nicotine play a key role. And in key role, we will use nicotinic receptor agonist. Its example is the nicotine patches and varenicline, or the drug which is specifically used, which play a key role in the which play a key role as an agonist action at the nicotinic receptors. So because you know that COPD, our first strategy is to avoid the smoking, and we will implicate this nicotinic receptor agonist for its management. Similarly, we'll use the other like mucolytics drugs, theophylline and bronchodilators like inhaled corticosteroid, short acting, long acting. These are all are the same as it is discussed in asthma. But here, one thing which was additional is the smoking cessation. It is managed by the use of nicotinic receptors. So that was all our point, and